Mountain Time in United States. We have a great program today from around the world. We have participants and speakers from every region of the world taking part today in a very interesting and very important theme, which is immunology, vaccines, and indeed the pandemic. Now, this is the 43rd webinar conference that has been taking place almost continuously, and some of you have been on this panel before, and I want to thank you all, our panelists here and our committee and so forth from around the world who have helped to put this together for running now for almost the same time as this pandemic. Now, before I introduce the speakers, can I first acknowledge some of our colleagues here. Des Kyle from Melbourne, who looks after the part of our committee, and Professor Dr. Lincoln Carrera, who's the president of the Confederation of the Latin American Medical Associations and Caribbean Medical Associations, who are all part of our program. And I'll introduce the speakers. Before that, let me introduce my co-chair, Professor Dr. Mary Matthew, who is going to co-chair and moderate this program. So can I hand it to you, Professor Mary?
Thank you, Dr. Russell, and welcome to our 43rd webinar. And today's webinar is really interesting. It's a burning topic, and I'm sure many of you will have questions regarding vaccines and immunology and the role of the pandemic, the effects of these in the COVID pandemic. And as usual, please feel free to put your questions in the chat box and we'll try to address them. And I think I will ask Dr. Derek, would you like to give the house rules, please? Derek, you're muted.
Yeah. Good evening and welcome, everyone. Wonderful to be here and looking forward to this very interesting session, which is absolutely the need of the hour, may I say, in this lull period of the COVID-19 pandemic and looking forward to the future. I have just put in a link into the chat box, which is the YouTube live streaming of this webinar. So you please feel free to share this with your friends and colleagues all over the world so that they can log in and watch it even if they don't have access to Zoom for any reason. In addition, the recording will also be available at this link, so you may access it or download it later on as you please. We will be monitoring the chat box, so I request all those who have logged in to this meeting to put in your questions or comments there, and also a request to our esteemed speakers and panelists. You may also access the chat box and address the questions directly so that in case we do not have time to bring you to the forefront or to get your question answered directly, you may address the question in the chat box so that we can save time. In addition, our speakers and panelists, if you have some interesting information or references that you would like to share, you may also share that in the chat box, because we have a large number of faculty from medicine, physiotherapy, dental, nursing, and all the allied streams of health sciences. So, and students as well from the medical colleges, nursing colleges. So that would be of interest to them. So you may post it there in the chat box, and the students especially would be able to access it and read it later. We will also take questions towards the end, so please put in your questions into the chat box so we can collate them and put them up to our panel in the second part of the So thanks for that, and back to you, Professor Mary.
Thank you, Derek. And I think Dr. Russell, now you would like to introduce the speakers.
Right. Without we have a very interesting, stimulating program. So without too much ado, let's get on with this. I'm going to introduce to you. I'll start with a very distinguished presenters, and then we have we'll move on to the very distinguished international panel that are going to represent the different regions of the world. And so we'll get an overview and understanding after hearing the presentations on what exactly, how is this impacting in the various regions of the world. So I'm delighted to introduce to you Dr. Mrna Vaccines. Dr. Mrna Vaccines graduated as an undergraduate in biochemistry from the McMaster University in Canada. And then, of course, she pursued her medical degree at the MS Ramaiah College in Bangalore in India, and completed her residency in internal medicine and a fellowship in allergy and clinical immunology at the Wisconsin Medical College at Wisconsin, USA, and has been a faculty at the university. She's also then served as the program director of the Infusion Center and joined the Advocate Aurora Health, where she continues to work as a clinician, and has been actively involved in contributing as a medical writer to some of our programs, particularly for those of you who know late Dr. K.K. Agarwal, who was the president of the Heart Care Foundation, but also the president of the Confederation of the Asian and Oceania Medical Associations of the World Medical Association. Okay, so we have Monica, and Monica is going to be talking on vaccines, past, present, and future. I'm then delighted also to introduce to you Professor Nandita Hazara, who, of course, is from Pune, but importantly, she's Dr. Nandita is a microbiologist, but has a special PhD in neurovirology from NIMANS, which is one of the leading centers for neurology and for psychiatry in Bangalore, and has a keen interest in science, communication, and particularly has taken a great interest in this COVID-19 pandemic. And very importantly, she's going to speak to you about the immune responses in SARS-CoV-2 and the role of the current vaccines. And then we have, I'm always delighted to bring Professor Barry Schwab, who has been on this program, contributed earlier to the program and to the knowledge. Professor Barry Schwab is from the University of Witwatersrand at Johannesburg, and he chairs the Ministerial Advisory Committee on COVID-19 vaccines for South Africa. And importantly, he's going to speak on the lessons from COVID-19 in South Africa. And for those of you who might remember, Professor Barry did talk to us some time ago and gave us an indication at that time, of the AstraZeneca vaccine and the South African variant, what was happening. So it's going to be interesting there. The other very distinguished panelists we have, I might as well introduce them. I'm very delighted again to bring to you Professor Dragan Primorac. Now, Professor Dragan is a very distinguished professor. He serves as a professor on both sides of the Atlantic, in Europe and as well as in Penn University in USA. But importantly, he's also been the Minister of Science and Education and I think sports for 4 years or so at in Croatia. So he's got a genetics background, but also public health professor and very actively involved in the pandemic. So and then have Professor Esper Calas, who is from the University of Sao Paulo in Brazil, a very distinguished full professor at the Department of Infectious and Parasitic Diseases at part of the Faculty of Medicine of the Sao Paulo University in Brazil. And I'm delighted he's here to join us and bring us and give us the information of that part of particularly the Latin American region of the world. And finally, also I'm delighted to have Dr. Paul Younger from Kenya. Dr. Paul Younger is an infectious disease physician. He's a scientist, a clinical epidemiologist, and specializes in vaccine and travel medicine and vaccine. And he's bringing to us the information on what's happening in East Africa, or for that part, that region of the African continent. Okay, so with all this here, I'm now delighted to welcome all of you. Thank you all for taking part, and we're going to start with, I think, Professor Nandita Hazara is going to start with the immune response to SARS-CoV-2, and then that'll be followed by the key presentation by Dr. Monica Vasudev, and then Professor Barry Schwab. Thank you. And over to you, Professor.
So very good evening to all of you. I think good morning, good afternoon to the others who are in different time zones. Today, before I begin, I'd like to thank Professor Russell, Dr. Derek, Dr. Mary. I think they actually pursued me to speak today. Otherwise, I would have given up a huge opportunity to interact with all of you. I think the varying immune responses and diverse clinical outcomes with SARS-CoV-2 virus, the infections have been raising questions about how the antiviral responses and the factors that kind of orchestrate the immunological memory and those that mediate robust protection actually exist. So without much ado, let me go on to the introduction to my talk. So basically, I'm going to speak to you a bit about the epidemiological triad, a bit about the non-specific and specific immune responses in the body, vaccines and a bit of how they work, because I think most of that will be covered by Monica, some SARS-CoV-2 myths busted, and what may work for coronaviruses. So sometime in March 2020, when I was kind of looking after the mental and physical health as an administrator of a small hospital somewhere in India, I realized that the SARS-CoV-2 virus had kind of started spreading angst and stress among a rather anxious population. And that is when I kind of realized that I really kind of found my reason for being. And that is exactly what Ikigai, the Japanese word, states. You should do what you love. You should do what you're good at. And if you do what you can, what's your profession, and finally find out what the world needs and match the four of them, you have your Ikigai. And it's because of that, I think probably March 20, I kind of found myself. From that time, I have kept myself open to, I've shared my number, shared my email, kept myself open to questions, to concerns, address the most basic of queries. And I feel every day I am grateful for, I live each day with gratitude, with abundance, and with a feeling of compassion. So without much ado, let's just get on to the epidemiologic triad. That is basically, we have the virus, the environment, and the host. And if you really look at the pathogen, something that I kind of studied during my PhD days, I worked on the measles virus. And it was kind of, it was abnormal because as the WhatsApp University was discussing things, I would realize that I'm kind of predicting what is going to happen next, because I'd studied the measles virus, worked with it so much that I kind of just knew what was going to happen next. And RNA viruses, basically, they exploit all known mechanisms of genetic variation and complexity to ensure survival. The virus I studied was also a measles virus, and I basically worked on the immune mechanisms or the clinical and immunological profile of patients with subacute sclerosing panencephalitis as part of my thesis work. And the basic thing about these RNA viruses is that they yield high amounts of virus per cell. They have a very short replication time, and they actually exist as complex and dynamic mutant swarms. It's very, very important for RNA viruses to have large population passages, which result in rapid fitness gain. So we basically look at an RNA virus as a fit, fit to the population. Whereas in contrast, if you have repeated bottleneck events, they lead to fitness losses with unusual deleterious mutations in the RNA. And these RNA viruses tolerate restricted types and numbers of mutations at any specific time point in evolution. At the same time, in the past 2 decades, at least 50 new RNA viruses, mostly RNA viruses, have emerged. And let me, confirm here that the pandemic of coronavirus is not the end. There are going to be more and more newer RNA viruses emerging. And this is probably because, the virus comes in contact with new potential hosts, facilitating host jumping as man kind of walks into forests, new professions, new diets, explores new environments. It is going to happen. There is going to be shifting or jumping of viruses from one host to another, mutate such that they become become comfortable with the new host. We've seen that with the SARS-CoV-1 and with the SARS-CoV virus and with the MERS virus as well. And this is basically favored by the genetic plasticity of RNA viruses and the alteration of the environment that has an effect on the viral traffic. Now, RNA viruses, mutations are the rule rather than exception. And I think when the world saw the first wave of the RNA of the SARS-CoV-2, it had a completely naive population. The virus had a completely naive population and did not need to behave differently. So what we saw in one country was actually repeated or replicated in varying degrees in another country. India got a huge boost of time, at least about 3 months. Thanks to technology, we were aware about the kind of issues and problems that were being faced in other countries. A lot of dissection on what was to be done, what could be done. So we were kind of getting things ready. I remember in our hospital, we kind of absolutely accelerated the speed of everything, whether it was checking the patients who were entering, making COVID-19 corridors, making COVID specific areas, green corridors and red corridors. And it really helped us. And in fact, enveloped RNA viruses are also easily susceptible to drying temperature and detergents, but still we still had to deal with this enveloped virus to a large extent, to a large degree. We didn't get much help from drying temperature or detergents. This is just to show the pango lineage or the variants which have created a lot of concern and which are being discussed through WhatsApp University. We have the alpha, the beta, the epsilon, and the delta variants. The delta plus is what is circulating in India at the moment. To the right, you can see that the variants of concern do change the behavior of the RNA virus. There is increased transmission. In the case of the alpha virus, there was increased severity, increased case fatality. There was no impact, however, on monoclonal antibody therapy. And finally, today, if you really look at the behavior of a virus in a host, it is predominantly a mix of the viral variant, the individual's genetic composition, which to a large extent we are not yet aware about. We don't have systems in place where we can determine the genetic composition of an individual. And of course, the risk factors like the comorbidities which the individual has. In fact, we have seen similar kind of behavior in families related by blood, like people related by blood behaving in the same way to the virus. So there have been multitude of deaths or multitude of serious complications in patients. As well as we've been seeing a lot of long COVID, and these long COVID manifestations, or COVID long haulers as they are called, we're seeing a lot of them in the patients who have had asymptomatic or mild disease. An interesting thing about long COVID is that the US, they have found that a third dose of the vaccine helps to shorten or stop long COVID. However, in India, there is an embargo on the vaccination being given before 3 months, 3 months before the second dose. 3 months before the COVID disease the individual has tested positive. So as yet, we don't know if our long haulers will really benefit from a dose of vaccine, and whether Covishield or Covaxin, which are what are available in India, will make a difference versus Pfizer and Moderna, which are there in the other countries. Now, coming to the host and the immune responses in the host. So this is basically to show you the kinds of receptors, the kind of locations where these ACE2 receptors or the TMPRSS2 receptors are present. And you can see there is a complete spectrum. The virus is likely to produce symptoms when it attaches to receptors at any of these locations. And that is why very early in the disease, I remember telling my medical officers, doctors, that don't look at fever as a symptom. It's not necessary that the individual should have fever. Ask for other symptoms. Ask for diarrhea. Ask for loss of taste. Ask for loss of smell. And that is how I think to a large extent we curtailed the spread of the disease by being very, very careful about, in our locality, by being very careful about making sure that contact tracing was done for each of these cases at that particular time. Now, I think I've just kept this talk a little basic. So we all know that innate immune system is critical for the early responses to the vaccine. And it is also critical in shaping the adaptive immune response. The innate immune system is basically consists of the local mucosal immunity, if you're looking at a virus which enters from the mucosal surfaces. And there is also the innate immune system, which is systemic, or where you have certain cells which are responsible for picking up parts of the virus and presenting it to the adaptive immune system. The adaptive immune system is involved in learning to drive the antigen-specific protection and immunological memory. So basically, we have an innate immune system, which is absolutely non-specific, which is going to help the body in the initial days of infection until it actually develops an immunological response to fight it. And the adaptive immune system is basically going to do that learning and then provide with certain immunological cells, which will kind of try and get rid of that foreign antigen or the virus out of the body. And the most important part is that the collaboration between the two is absolutely essential if the body has to get rid of the coronavirus, the virus completely. Now, the issue is that I think the corroborative of the immune response as far as vaccines are concerned is predominantly believed to be the antibody response. So anytime an infection happens or a vaccine is given, it is assumed that the antibody response is what is going to tell you about how good the response to the virus is. Unfortunately, SARS-CoV-2 does not work like that. In fact, neither do any of the coronaviruses. They produce antibodies. Unfortunately, these antibodies, we still don't know whether they are neutralizing or not. Only recently, neutralizing antibody tests have been introduced into the system to determine the neutralizing antibody titers. Just to diverge from here at this point, neutralizing antibodies are antibodies which help to kind of bind the virus and prevent it from entering a cell. For a virus to cause infection, it needs a receptor and it needs some part of the virus. For example, in the SARS-CoV-2, the spike protein, which has the spike protein 1, the S1 and the RBD and the S2. So the S1 is what is basically responsible for going ahead and binding with the receptor, like I told you, the ACE2 receptors. In case the antibodies neutralize the S1 receptor, there is going to be no chance of the virus reaching or attaching onto the cell. So we call it as attachment, penetration, uptake. So there is no attachment. There will be therefore no penetration into the epithelial cell. There will be no uptake. So the neutralizing antibodies titers we don't know. And apart from that, the antibodies, different reports say stay for about 4 to 8 months, but we don't know how protective they are. The other issue that we have faced in SARS-CoV-2 as regards diagnosis or detection is there is about only 15 to 8% who really manifest with the disease. The remaining 85 to 92% have asymptomatic or pre-symptomatic infection. Asymptomatic or pre-symptomatic infection means the individual never knows whether he has actually caught the infection or not. And how infectious is the individual is, what is the load of the virus that he sheds, what duration does he shed? If he is shedding it, is it only RNA or is it the virus per se, which is infectious, is completely unknown. So amidst all these issues and premises, in March 2020, we saw our July to August 2020, we saw our first wave. And then India has now seen it's just kind of recovering from the tremendous second wave. We are still seeing a few cases here and there. It had touched zero in between about a week, 10 days back. But again, we find about 4 to 6 cases still turning positive in our setup. So this is just to show you the coronavirus. It has first, it's not a very sturdy virus. Like I told you, it's an enveloped viruses. Enveloped viruses are relatively quite weak and unable to withstand heat, sunlight, drying, exposure to detergents. However, it has to also go through certain barriers of the mucus which is present on the epithelial cell. It also has to battle collectins. Once the virus attaches to the cell and goes in, the viral proteins are kind of broken down and there is release of interferon alpha by the epithelial cell, which kind of makes the epithelial cells around it resistant to the virus. The complete game is between the virus and the host as to who finally wins. And though you have gamma delta T cells and NK cells, which kind of get signals from these cells and then pass them on in the form of interferon gamma and actually stimulate the classical dendritic cells or the plasmacytic dendritic cells to kind of present these antigens on TLRs, which finally stimulate the cytotoxic lymphocytes, and even there may be even direct stimulation of the B cells to release antibodies like IgM, IgG, and IgA. There is also the T cell mediated immunity, which you could see in form of the Th1 or the Th2 responses, and of course, release of interferon gamma, the release of perforins and granzymes from the cytotoxic T cells, which try and kill the infected epithelial cells, tremendously trying to reduce the viral load. Now, the immune response in the case of a vaccine or is basically like the way I'm just showing it to you here. You have the injection of the protein. The protein, basically the antigens are sensed by the innate immune cells. The dendritic cells, as you can see, these dendritic cells have projections, and that actually increases the surface area to kind of pick up antigens from different sites. And the immature dendritic cells are the ones which are kind of circulating in the system from lymph node to site and back. And these could be Langerhans cells in the skin. They could be Kupffer cells in the, liver. And so these dendritic cells are basically transversing between the skin, say for example, and the lymph node, and they kind of pick up these antigens. Basically they travel to the secondary lymphoid organs where they present the antigen to the T cells, and they load up the follicular dendritic cells with antigens to present to B cells. Once this is done, the T cells provide help to the B cells and convert to antibody secreting cells that establish lifelong immunity in the bone marrow. In fact, you have the plasmas, they release about 2,000 antibodies per second. And you do have certain plasma cells which kind of go and find a niche in the bone marrow where they kind of sit there waiting for such stimulus again appearing, which could be the infection, or for example, if this was the prime dose of the vaccine, then for the booster dose of the vaccine. The B cell selection occurs in waves. First wave, you have the extrafollicular B cell selection, which gives rise to the first B cells, which are somatically hypermutated, because at that time, the T cell response is still just evolving. Whereas in the second wave, you have the follicular B cell selection, which gives rise to affinity maturation in the germinal center, and thus induction of both memory and long-lived plasma cell. That is the reason why you need 2 doses of the vaccine for most vaccines, and so that both the waves can be looked after. Natural infection in COVID-19 does not seem to bring about as much of an immune response as is seen post-vaccine. In fact, vaccination has been seen to reduce morbidity at least 40 to 50% post-vaccination. However, this statement is open for discussion, because I'm only talking about antibody-mediated immune responses. As yet, T cell and memory immune responses have not been analyzed following natural infection versus the vaccination. So basically, once there is transmission of, or coughing or spread of the virus through the production of droplets, fomites, or even aerosols, what really happens is you have the virus, which, like I said, in an external environment actually doesn't survive. But suppose it survives this environment with sunlight, drying, UV light, acid pH, soap, and alcohol. It actually has to again kind of battle the innate immune responses consisting of the skin, the hair, and the mucus in the nose. It has to battle the innate defenses, which consist of the mast cells, the natural killer cells, the complement system, and the phagocytes. And these physical barriers, basically, like I've shown you here, are the epithelial cells, mucus, which is being secreted by the mucus gland, and the defensins. Even the tight junctions between the epithelial cells help. And you also have these cells circulating, these immune cells which are circulating in the mucosa. So the NKT cells, the delta gamma T cells, you have the ILCs, which are circulating and actually form a very, very important part of the local mucosal immune response. The reason why all the vaccines that have been developed till date for the SARS-CoV-2 have not been able to prevent infection is because they are not mucosal vaccines. The minute you have mucosal memory for a virus, it is able to prevent infection because it is able to produce neutralizing antibodies on the surface of the mucosa, which is going to at least try and reduce the entry of the virus, the amount of virus that enters, or completely stop the amount of virus that enters the epithelial, goes through the epithelial lining. Now, you also have in the mucosa the macrophages, which are basically going to be responsible, of course, I'm showing bacteria here, these are not bacteria, but which are going to be responsible for some amount of phagocytosis, which is also going to be releasing pro-inflammatory factors. And this is this is in the lung that this diagram represents the lung. You're also going to have neutrophils. And the innate immunity is responsible, basically acts like the viral sensors. It provides an interferon response. It provides a cytokine response, and it is the balance between the interferon response and the cytokine response, which is believed to, at the end of the first week, result in the mismatch. The mismatch between this is what has been seen to cause the cytokine storm in individuals. And finally, basically, it acts through the TLRs, 7 and 8, RIG1 and the MDAS. And these TLRs, or the toll-like receptors, are present on the surface of membranes, which then finally acts through the NF-kappa beta and the IRF3 or the IRF7 path to stimulate the eosinophils, monocytes, macrophages, and dendritic cells. And this is what is finally going to help in the activation of the adaptive immunity. And these adaptive immunity, the link between the innate and the adaptive immunity are the gamma delta T cells, the NKT cells, and of course, sometimes even believed to be our dendritic cells. The adaptive immune response to viral infections, basically, it has been found to eliminate the viral infections that have outpaced the innate immune control. And it is predominantly the CD8 T cells which migrate to the sites of infection, where they kill the virally infected cells. The early responding B cells, they produce and release virus-specific IgM, and the CD4 T helper cells finally promote the class switching of the germinal center B cells from IgM to IgG or IgA. Now, IgA is the antibody which is what is required on the surface of the mucosal epithelium from the mouth down, even on the even in the lung, on the bronchial and the tracheal, bronchial and the bronchoalveolar surfaces. And that is what is actually going to be responsible for kind of preventing the infection from gaining access. Now, after virus clearance, a pool of memory cells remains, like I mentioned, and these are going to be reactivated upon reinfection with the same virus. Now, what is the role of vaccination in the COVID-19 pandemic? So just quickly, it would be unfair to not mention Edward Jenner, an English physician who actually brought in vaccination sometime in the 1760s. Of course, Louis Pasteur, who established the germ theory of disease, and Robert Koch, who I believe used to, I was reading and it says that Robert Koch and Louis Pasteur would be constantly squabbling because Robert Koch said, how can you look for an agent without proving that it is actually the cause of the disease? And Robert Koch therefore made the Koch's postulates. But all three of them really, in fact, Jenner for modernization of immunization, Robert Koch for making media in which organisms could be grown. I'm talking about bacteria, but they're the ones who actually brought in vaccine development. And till date, we have this complete gamut of vaccines which have been developed. And even though the vaccine life cycle is really, really long, I think it is kudos to the scientists in a global world who have worked tirelessly together to bring about vaccine development at various stages and have been able to control a pandemic of such a large magnitude. So when you have a new pathogen, no antibody, the only way you can actually bring in an antibody is through vaccine. So the two doses, basically, the first, the primary antigen challenge to teach, and the secondary antigen challenge to remember. This, of course, doesn't work for the Janssen's, that is the Johnson & Johnson vaccine. You have only a single dose there. And Viral vaccines, I think Monica will be covering in detail, so I'm not really going to go over it. You could have the virus, actual virus, viral vectors, nucleic acid vaccines, and of course, protein-based vaccines. I think most of us are familiar with these. You can have a whole microbe approach where you can have an inactivated vaccine, live attenuated vaccine, or a viral vector vaccine, which we have seen being used in India. The Covishield, the inactivated vaccine, of course, was the Covaxin. The mRNA vaccine basically is made with instructions to make viral proteins, delivered as an injection. The mRNA is used to make viral proteins and generates an immune response. And with the low amounts, reduced amounts of vaccine, it is very, very important to determine the key populations for immunization, so that it's basically important to have a smart approach to vaccination rather than generalized approach to vaccination. So just a word about vaccine hesitancy and misinformation. Natural immunity is good enough. Not to disagree. Vaccine is dangerous, has microparticles, will kill you after 15 years. I mean, these are the kind of things I've heard being discussed on podcasts. Absolutely not. I have actually caught people and told them, vaccinate yourself. This was the time when vaccination for the Covishield had started, and I realized that vaccine hesitancy was there. So in a population that I could kind of influence, I did speak to them and did tell them that it is important to go ahead with vaccination. We have seen morbidity and mortality in people who have stayed away from vaccines. Science educators, communicators have always been at the receiving end, but I think we continue to be a cohesive community working for the better of mankind. And just to say that whatever we may talk about variants, about management, finally, it is human behavior that is more relevant than any virus mutation. And we know the spread of cases that happens from one person, how it spreads. Unfortunately, it is the people at risk are the children now, as is being said, because they are not vaccinated. And of course, the geriatric population and the population with risk factors. So coming back to Ikigai, I think very, very important to remember these 10 rules, especially when it comes to life as it is today. Stay active, take it slow, surround yourself with good friends, live in the moment, give thanks, reconnect with nature, and follow your Ikigai. Thank you for your time. I finished.
Thank you, Dr. Nandita. Thank you very much, and we'll take other things later for the discussion. So let me now invite Dr. Monica to take to put her slides up, and she's going to take us to vaccines past, present, and the future. Thank you, and over to you, Professor Dr. Monica.
Sounds good, and thank you again. Thank you, Nandita. It's amazing to dovetail after your presentation, and thank you, Dr. D'Souza. Thank you to everybody on this esteemed panel and organization bringing education out to the world. And this is definitely a very, very important topic that we are talking, and it remains an important topic as we go through the stages of this pandemic. I wanted to use this time today to talk about the vaccines in terms of the past, present, and future, understanding where we came from to be where we are today, and some of the challenges that we continue to face and anticipate to face in the future. We can't start a talk on COVID without understanding what the burden of the morbidity and the mortality has been on the world. This is data from Worldometer from July 2nd. And all of these numbers are extremely large in terms of cases, 183 million, deaths almost up to 4 million, and those who have recovered up to 200 million. It doesn't really capture the true extent and how this virus and pandemic has gripped the world Even though the number of 168 million has been recovered, there are so many people who continue to have long-term consequences regarding the infection and the loss of time from their lives because of this infection. Talking about vaccines also requires a discussion about herd immunity, also known as community immunity. This is a simple graphic that shows various dots represent individuals in a population, represented as blue if they are susceptible to catching the virus, red that they are infectious to spread the virus, and green if they are immune either through prior infection or through immunization. We have two scenarios on the left, those who are not vaccinated and those who are vaccinated at 75%. Underneath this designation of vaccination, we have what's known as the R0 factor. The R0 you might have seen before represents how many people will be infected from one person who is infected, how much of a spread is there. What you see with an R0 factor of 2, you have one infectious individual in red who can then spread it on to 2 other people in this panel in the middle. In a scenario of no vaccinations and an R0 factor of 2, you can see a quick spread in the extreme right panel. In the scenarios where those who are 75% vaccinated, whether or not the R0 factor of 2 or there's an R0 factor of 5, on the right, you see that there is a large number of population who are immune because they were either achieving immunity through prior immunization or through infection if they have not been immunized. And this speaks to why we need to have immunization in addition to natural infection in the community to stop the spread. Dr. Hazra had mentioned earlier about the components of the SARS-CoV-2 virus, and I wanted to show you the different cell surface proteins that could be potential targets by the antibodies of natural infection. You have the membrane protein, the nucleocapsid protein, the envelope protein, and everyone is familiar with the spike protein, the S. If your immunity is developing antibodies to other components of the cell surface, you can see that it may not provide effective neutralization of the virus, and it is very important to target the spike protein. This is another depiction of the spike protein. We consider the spike protein to be like an umbrella, and the canopy tip as the most important part. And that tip is a receptor binding domain that you can see in the green over here. But there is also the NTD domain, you have the S2 unit, and then the S1 unit that encompass the NTD that Dr. Hazra had spoken about earlier. And I'm just showing you this diagram to illustrate the fact that the antibodies to the spike protein also can be variable in terms of what part of the spike protein it is identifying. We talked about antibody levels as well, and measuring antibody levels is one way, one particular assessment of the response or immune response to infection or immunization. Dr. Nandita talked about the humoral immunity, which is antibodies, and the cell-mediated immunity, which is the T cells. And antibodies are a product of the humoral immunity, or the immunity that is generated by B cells. What we know about antibodies is that they can appear 1 to 3 weeks after symptoms appear. We know that immune responses differ dramatically between those who are asymptomatic versus those that are symptomatic. The individual that is hospitalized, critical care, intubated, will likely have generated much higher levels of neutralizing antibodies than the person that is detected to have asymptomatic disease on pre-screening testing prior to a planned procedure. So there is difference in immune responses between these two individuals. It is unclear the usefulness of monitoring antibody responses as a measure of the presence and duration of immunity to SARS-CoV-2. The immune system is highly complex. It is not just antibody mediated, and this is what this concept is. And using antibody measurements should just be one piece of the entire assessment of risk stratification. just as important as hand washing, social distancing, and all the other measures that we have also been doing for so many months. We also know that once you do have antibodies, that they can rapidly dissipate, that they can last potentially no more than 10 months. We are still getting more information regarding this, but measuring antibodies, I believe, is a snapshot in time and not representative of the entire picture. We do know that T cells and memory B cells have the capacity to recall and initiate sterilizing immune responses, even if you don't have antibody levels. We have patients who have known immune defects where they can't make antibodies. There's a condition called common variable immune deficiency where they have low to undetectable antibody levels. And we still encourage immunization of them so that they may have B cells or T cells that can potentially generate some immune response. We do see the availability of commercial systems to test this humoral immunity, even to the very specific receptor binding domain of the spike protein. And the CPAS technology is one that was developed by Duke Medical Center in Singapore. And I highlight this to show you that there are tests that are available that are even more sophisticated than your baseline antibody test. And this diagram here is to show you the difference in the variation in the immune response to natural infection. So this is not a diagram representing those who've been immunized. What this shows are memory B cells, which are the ones that produce specific antibodies, example to the receptor binding domain. You have regular antibody levels that you can assess. The two different types of T lymphocytes, the T helper cells, the cytotoxic T lymphocytes in response to the vaccine. So looking at these four markers of the immune response and looking at every combination and permutation in terms of what's present and what's negative, we can then assess what is the level of immune response to natural infection 1 month out and again 6 months out from infection. Not only at the 1 month mark are you seeing that there's a variation in the types of immune responses, but also at the 6 month mark that this changes and you end up losing some of the immune responses, where the black dot represents mounting an immune response in all four of these categories. So it's not a simple story of just measuring antibody levels to assess immune protection. And that leads us to the immunization as being the proverbial light at the end of the tunnel, as helping us as a way to forge our way out of this pandemic. What are we looking for an efficacious vaccine? We have someone who's exposed to the virus. We would like to prevent infection. If we can't prevent infection, we'd like to have these individuals remain asymptomatic. Even if they get the infection, we're trying to prevent the COVID-19 disease. We're then trying to prevent hospitalization, critical care use, and to prevent death. We have seen surges of cases, overwhelming healthcare systems across the world at different time points in this pandemic, and we'd like to prevent transmission. And this is what the goals were of developing an efficacious COVID-19 vaccine. Dr. Hazrat mentioned this earlier and alluded to this about how quickly we were able, and the world was able to see that these vaccines have been developed. I like this graphic to show the comparison in time and development between COVID-19, which was a duration of 1 year, up to 105 years for typhoid. HIV is still undergoing research trials for developing a vaccine. What you are seeing with the COVID-19 is the ability to generate various vaccines given the existing technology that we have, and an intense amount of collaboration that also has been unprecedented. As a summary of what has happened in that past year that led to the development of the vaccine, this was a nice milestone timeline that was posted by Eric Topol on Twitter, showing when the first documented COVID-19 illness was, which was December 1st, unpublicized November 17th, and how all the way until December 11th, we initiated phase 1A of vaccination efforts for healthcare professionals. And that is an incredible timeline to be witness to. Going through the history of how the vaccine has been developed, These trials began immediately after the COVID-19 pandemic began. The vaccine development benefited significantly because of the rapid sequencing ability of the SARS-CoV-2 genome. And again, the spike protein was a key target for the immune system. This shows you where the genome information was publicized as now being available. And what's important to notice in this is that this was January 10th. We just said that the first unpublicized infection was November 17th. And in January 10th, you are now having the entire genome available for the entire world. And you can see the number of organizations and institutions that were involved in this process. You can see the Shanghai Public Health Clinical Center and School of Public Health that collaborated with the Central Hospital of Wuhan. You have another university, the Haozhong University of Science and Technology, the Wuhan Center for Disease Control and Prevention, the National Institute for Communicable Disease Control and Prevention, the Chinese Center for Disease Control, and then we also have the University of Sydney in Australia. The technology that was used to drive the vaccine and the pathogen sequence was based on understanding the different forms that the spike protein had on the cell surface. The spike protein is not static. There's two different forms that it can exist on the cell surface, which is the pre-fusion and the post-fusion form. This paper talks about the prototype in terms of stabilizing similar viruses or other viruses such as the SARS-CoV-2, and also understanding how to stabilize this using a lipid nanoparticle platform so that the vaccine can be developed. So the vaccine development for the COVID-19 vaccines utilized information that we had from research that was done on other viruses. And this is a very busy paper, and all this is showing you is that you have multiple different viruses since 2002 that have been studied, including HIV, you have the MERS, and then you end up having the SARS-CoV-S, and then the SARS-CoV-2. And all this is showing is that there's a stabilization of the post-fusion form. And again, there's the pre-fusion and post-fusion forms of the spike protein on the cell surface. And by stabilizing it, by changing one amino acid by the name of proline, they were able to then have the structure called a post-fusion form that they were able to utilize in developing the vaccine. And this is another graphic to show you what the differences in the pre-fusion and the post-fusion forms of the spike protein, and that this virus can carry it. So it is not so simple in terms of just making the vaccine against a certain protein. It's understanding how does that protein behave in the body to be able to make sure that we develop an effective target for our vaccines. There's a lot of information, and I know that many of you have already understood most of the information of the vaccines that are available. I like this slide because it gives you a lot of information in terms of what are the different types of vaccine, the different manufacturers that have been involved. Many of them look familiar to you. At the time that this slide was released, it could have been that some of these vaccines had not been in use yet, and which is now the case. The two major vaccines that we have in the United States are the viral vector vaccines. The AstraZeneca is the one that we have available. The Johnson & Johnson is the one that's available, but the AstraZeneca has been very commonly identified as being used worldwide. We also have the initial mRNA vaccines that were given emergency use authorization here, and that was with the Pfizer vaccine and the Mrna Vaccine. There are emerging reports on Noblevax, which is a subunit vaccine. It is my understanding that a DNA-based vaccine will be available in the next few weeks. There are many countries that are using Sinopharm and Sinovac, which are the inactivated vaccines. So within a year, now a year and a half, we have had not only the availability of vaccines, but we have vaccines that are being developed by utilizing different methodologies to become available. And this is going to become important, especially when we're looking at the future in terms of what is next. Our major players, again, in the United States are the mRNA vaccines, which is the Pfizer and the BioNTech, and also the Moderna. They require 2 doses. We have the Johnson & Johnson, which is a single-dose vaccine, versus the AstraZeneca that's available in many places that are 2 doses. A little closer look at the mRNA vaccine. I know Dr. Hazra had already spoken to this a little earlier. Again, you have the mRNA that's packaged in that lipid nanoparticle package. And that was what I was alluding to with the earlier publication in terms of the science that went into developing these vaccines. It is then taken up by the host cell. It utilizes the host ribosome to produce the protein, or the SARS-CoV-2 spike protein, what is then presented to stimulate the immune response. The viral vector vaccine, the AstraZeneca and the Johnson & Johnson utilize a non-replicating viral vector, such as the adenovirus. The virus is then taken up into the body. It can or possibly not replicate depending on which type of vector is used. It's taken up by the immune cells. In this case, it's like an antigen presenting cell, such as a dendritic cell, broken down, presented on its cell surface, and then can elicit an immune response through very specific MHC class restriction. I'd like to make one word on antibody-dependent enhancement. This is a process whereby the vaccine-induced antibodies, which bind with the virus, can actually enhance a negative effect as opposed to producing the positive desired effect. This was most classically seen with the dengue virus, and there has been no evidence of ADE from current vaccine trials, nor have we had any reports related to this since the release of these vaccines. Where are we now in the world in terms of vaccine administration? This is a graphic of the world. This is data from July 2nd, whereby each color depicts the percentage of people who have received at least 1 dose of the vaccine, where the darker the color of blue, the more of the population has received 1 dose. You can see that Canada has done very well. This is a reflection in the change of this darkening of this color only in the last few weeks as shipments of vaccines became available. They also allowed mixing and matching of vaccines where they were not restricted to what they received on their first dose. So it's about accessibility and making sure that the vaccine can actually be administered. And that is what we saw in the last few weeks in Canada. So the news of the hour, the really very important topic right now is the Delta variant. The Delta variant we saw surging in Delhi, especially in March and April of this past year, with complete utilization of all available healthcare resources, very stressful amount of utilization of healthcare resources in this single area. And now the question is whether or not these vaccines are effective against this particular variant. This was a small report that was published on May 10th. They looked at 25 people who received 2 doses of Moderna or Pfizer, and what they found was that it produced enough antibodies to neutralize the variant. So looking at one particular immune response to the Delta variant. And then on May 28th, they looked at data that was shown, and I believe this is a preprint, it's not gone through peer review process yet, that it was 88% efficacy towards a Delta variant after 2 doses, and that efficacy against the Delta variant was 33% after 1 dose. What else do we know about the immune stimulation with the use of the Pfizer and Moderna vaccines? Dr. Hazra had talked about the germinal centers. Germinal centers are located in lymph nodes, and these are areas that produce the highly specific memory B cells, whereby the longer you have the presence of these germinal centers reflects a much larger and robust immune response to the immunization. So this paper here was published on just recently on the 28th of June. It looked at the germinal centers from axillary lymph nodes of 14 patients who received the Pfizer vaccine. And it demonstrated that there were adequate and strong immune responses that lasted weeks after the initial immunization, and that it was even a more robust response after the second dose. They found similar findings with the Mrna vaccine. I'd like to talk now about the Noblevax, and this is new data also that was released earlier this week. This is a recombinant vaccine. It's protein technology. It uses familiar technology. It's been used for hepatitis B and pertussis vaccines. There are 2 doses that are given 3 weeks apart. It was found to be 90% effective overall. It's 91% protective in people deemed to be at high risk of a bad outcome from a COVID-19 infection. And very importantly, it was 93% protective against 8 circulating variants of concern. What is very pragmatic is that this vaccine can be stored in a refrigerator for up to 6 months, and once removed, remains viable for 24 hours. This has the ability of being able to be administered in areas that may not have been reached by the vaccines such as Pfizer, which required extreme cold storage. This is the Noblevax summary statement. And again, in the blue bar, you can see running across that it is 90.4% overall efficacious, 100% against moderate to severe disease, 93.2% against variants of interest and concern, 91% efficacious in high-risk populations. This is the information that they showed regarding the variants of concern and variants of interest. And then they're stating now that they expect to share further details, and this was through the Prevent-19 study. They're looking at adolescents now from ages 12 to 17, and they're looking at the recently completed enrollment of 2,200 patients. So we are expecting to hear more information regarding Noblevax, and this is one that I think we should be watching for in the next few months. So again, I've been talking a lot about immunity. We talked a lot about the immunity of natural infection versus that from vaccination. Again, I think it is important that we have a combination of both. The messenger RNA vaccine antibody responses target a broad range of variants, carrying even just a single letter changes in the key portion of the spike protein. The acquired immunity may have different levels of protection to emerging variants. It is important to have both natural and vaccine-generated immunity because it can differ in how they recognize new viral variants. The acquired vaccine antibodies are more likely to target the new variants potently, even when the variants carry mutations in the receptor binding domain. And those who've recovered from a COVID-19 infection still stand to benefit from getting vaccinated. And these are some of the talking points that you can use towards those who have vaccine hesitancy. I have patients that come up to me and say, even physicians who have said to me, I had COVID-19 in last fall. There's no need for me to get the vaccination. I'm already immune. And I think that this is a reason that you can use to show that it is important to get vaccinated because it is important to be protected against the variants that we are seeing. And this brings me to the concept of hybrid immunity. This was also alluded to earlier by Dr. Hazra. And this shows that those who have natural immunity can have some responses in terms of memory B cells, CD4 T cells, CD8 T cell responses, and antibodies. If you get the vaccine, you will have most likely better immunity as a result of the vaccine. But look at what happens if you had both a natural infection followed by vaccine. You have a much stronger response. This is called hybrid vigor. And this occurs when different plant lines are bred together and the hybrid is a much stronger plant. So this is a concept that is familiar even in the world of botany. Something similar happens when natural immunity is combined with vaccine-generated immunity, resulting in 25 to 100 times higher antibody responses that's driven by memory B cells, CD4 T cells, and broader cross-protection from variants. And this diagram comes from this publication. And it also states that increase in variant neutralizing antibodies after vaccination of previously infected SARS-CoV-2 infected persons, meaning that those who were infected were then vaccinated. And this is happening due to a recall of diverse and high quality memory B cells generated after the original infection. And this is a very important concept to understand as to why immunization is important in those who've been, who've had infections. The next concept that I want to talk about that will have implications on how we move forward with vaccination drives is the heterologous prime and boost concept, also known as mix and matching. So this was a study that was done in England. It was called COMPACOV. It looked at immune responses in patients who've been given heterologous prime boost vaccine schedules, first by given AstraZeneca, followed by Pfizer. And what they found was that the mixing vaccines led to a higher reactogenicity and but could also lead to more common vaccine-related side effects, such as fever. The results that were published as a preprint in Lancet on the 25th of June. Again, this is very recent data. The patients received AstraZeneca, 4 weeks later received Pfizer. And what they found is that they had a much higher increase in antibodies that were found to the spike protein compared to 2 doses of the AstraZeneca. This is the Noblevax trial that was done in Spain. It included 663 people. They received the AstraZeneca followed by the Pfizer. On the left, what you are seeing is a log scale of the antibody responses. On the x-axis, you're seeing the time since vaccination. The control group are those who received 2 doses of the AstraZeneca vaccine, whereas the intervention group, which is in the orange boxes, are representing those who received the AstraZeneca followed by the Pfizer-BioNTech vaccine. And as soon as 7 days, you are now beginning to see a huge separation between those who received 2 doses of AstraZeneca versus those who mixed and matched, and that this is going across time to 14 days. So that brings me to now, what are we looking for in the future? This was also alluded to earlier in terms of receiving the 3rd dose for those who had the 2 doses of a 2-dose vaccine schedule. When are we going to have the 3rd dose? Should be giving the 3rd dose in certain situations. We are all facing patients who express vaccine hesitancy and the fear related to these vaccines. This is not a new concept. Here you're seeing Edward Jenner inoculating women, and the fear that they have that they will develop, and you can see all these cow parts emerging from their faces. So this is nothing new. This is something that we have faced for years. What are the concerns that our patients are having? Our patients are having concerns related to anaphylaxis. There were many cases at the beginning of the onset of the immunization efforts regarding anaphylaxis or anaphylaxis-like events. In terms of the US world, with the vaccines that we have available, it was felt that the ingredient that was involved in anaphylaxis was related to polyethylene glycol or polysorbate 80, which are ubiquitous compounds where most of our patients have been exposed to this in the past. Even if they had a bowel prep prior to colonoscopy with polyethylene glycol, they had tolerated that. We have seen the publications of ways to assess these patients to understand what is the risk stratification of getting their next dose, should they have had an adverse event in their first dose. And we've also seen reports related to the COVID arm, patients who are developing localized redness persisting for a long time following the first dose and who subsequently tolerate the second dose. I don't hear as much now related to anaphylaxis today as we did when these vaccines first became available. It is important to use whatever adverse reporting system you have locally so that there can be any identification and any clustering of adverse events. The second thing that was noted was a cerebral venous sinus thrombosis that was associated with thrombocytopenia. There were reports related to this with AstraZeneca as well as with Johnson & Johnson. In the United States, there was a pause for about a week related to this to understand what was the impact and breadth of this side effect with this vaccine. and it was allowed to be restarted after a week of review. And then finally, with the myocarditis that we were seeing with the adolescents with the Pfizer vaccine, which has been largely been mild, treated with NSAIDs and have not required a lot of hospitalizations. But these reports are real. We need to be able to understand what they are. We need to be able to understand what is the true risk, a statistical risk of these events compared to other things that we do and are accepted okay in terms of risk acceptance, given the benefit of these vaccines today. So that risk-benefit ratio has to be discussed with all these patients who are expressing or a desire for a further conversation related to these vaccines. I'd like to end off on the issues related to the ethics surrounding these vaccines. There's a lot of discussion regarding mandatory vaccination. We have now had, in my area, there's one hospital system that has mandated that all employees be vaccinated, and there are situations for ethical exemptions. Who should we be recommending booster doses to? Should it be in immunocompromised conditions? Should it be those who are experiencing long COVID? Who should be allowed to get third doses or additional doses when we don't have direction on that right now? A lot of issues related to unequal distribution of vaccines. Where are we wasting vaccines? Where are vials being opened and the entire doses not being utilized? Are vaccines being distributed only to where you have healthcare systems? What if you don't have healthcare systems in more rural areas? Is there access to vaccine compromised? The issue of vaccine passports, the WHO and the COVAX program recently released a report that all vaccines from the world should be considered equal, that there should not be a hierarchy in terms of one vaccine being considered better than the other. This is just the tip of the iceberg in terms of ethical issues related to vaccines. I'm sure all of you can share a story with us in terms of scenarios that you have faced. On the right here, you're just seeing data from, I think it was early February, of adults being polled. It was January 28th to January 31st from sample from Brazil in China, asking whether or not COVID-19 vaccination should be mandatory. And it's a pretty high number in some areas. We need to set an example in terms of vaccinations. For those of us who are not vaccinated yet, which I'm sure is not very many, it is important that we also utilize the system to be immunized. I'd like to say thank you again to the platform today in terms of giving me an opportunity to speak. I would love any feedback to Dr. D'Souza, Dr. Mary Matthew, Dr. Derek D'Souza, the esteemed international panel and co-speaker, as well as to all the guests today who've shared their time to listen to me today. Final word, I'd like to dedicate this talk to my uncle, Dr. KK Agarwal, who was a thought leader and an influencer in medical to provide medical care and bring medical care to the masses. And I do hope that this platform continues to do the same thing. Thank you.
Thank you. Thank you, Monica. What a wonderful presentation. And indeed, Dr. KK Agarwal, a dear friend of mine, has been 4 times on this, on our program. And he was to be there in the last time, but unfortunately, he was not there before. I mean, we lost him before that in his dedication continuously every Saturday, and I'm very grateful and remember him always. So thank you very much for your presentation, and we'll be having you on the panel. So let's now go on to Professor Barry Schwab. Can I hand over to you, Professor Barry? Now, this is interesting because Professor Barry Schwab is going to speak on the lessons from the COVID-19 in South Africa. Now, we've set the scene. We've had this whole wonderful expose, as it were, and now you're going to tell us the impact and what's happening and where we are from your last presentation to where we are today in July 2021. Thank you, and over to you, Barry.
Yeah, thank you very much. Thank you very much, Professor D'Souza, Professor Mary Matthew, and thank you very much also to the previous speakers and to the panel. Thank you to the speakers for actually, as you say, setting the scene. It's made my job a lot easier. I must apologize, Professor D'Souza. I have to rush off just after this. I've got an appointment actually at 4 o'clock, in fact, so I'll have to be a little bit brief. I'll just go straight on to my slide presentation, if I may. Share screen. I hope it's coming through. Yeah, what I'd like to do is just review what has happened in South Africa, because I think it raises a lot of questions. South Africa, I think, has been notorious for being the first place in the world where the most vaccine-resistant variant was first detected. Now, I do underline first detected. It's not a South African variant. It's a variant first detected in South Africa, and I think there's quite a big difference between those two concepts. So let me just go through this. We've, like I think many countries in the world, have 3 waves. We had our first wave in the winter, in our winter of 2020, and then the second wave in the summer season, starting in November, going through about February, a more intense wave, the second wave, and we now from about May onwards, early May, are going to a very intense third wave, probably going to be the most intense of all 3 waves. And this, as I said before, does raise a lot of questions, particularly around immunity, and also particularly around what tools we can use, what tools we need, because I think this is a critical thing in managing. I think around the world have been surprised by these waves, by these epidemics within the pandemic of COVID. And I think it would be extremely important from a management point of view to have tools in which we can at least have some way of predicting what the impact's going to be and what the new variants are going to be when they arise. And this is really what I want to discuss. Now, South Africa, like many countries, and South Africa has got a very good genomic monitoring system. We've got 5 quite sophisticated laboratories scattered around the country, which are able to fairly accurately look at the genomic evolution of the viruses and the evolution of new variants. So when you look at the first wave, there were a number of lineages which were generated, variants of interest, but no variants of concern, like I think anywhere else in the world. But of course, it was a virgin soil epidemic, so it had its impact because of the lack of immunity in the population, as the previous 2 speakers have alluded to. That was the first wave. Then we come to the second wave, the severe second wave. Now, when you look at this wave, it really started at the end of October, and that was the advent of the variant which is associated with South Africa, the 351, the B1.351 or 501V2, or what is now called the beta variant. We started detecting that towards the end of October, beginning of November, and this very rapidly became the dominant variant in the country. If you look at March, for example, 99% of all isolates which are genotyped were in fact of the beta variant. We had a few cases of Delta variant, mainly from travelers coming into the country, but it seemed to be fairly confined. And we were hoping that it would be confined, and unfortunately we were rather disappointed, as I'll show you just now. This B351 or the beta variant, very much a Southern African variant, not only South Africa, but also many neighboring countries in Africa, Zimbabwe, Mozambique, Botswana, Zambia, less so in other parts of Africa, and to some extent in other countries as well. And unfortunately, this particular variant has got mutations in the receptor binding domain. Monica alluded to it just now. There are 3 main variants, the E384, the 417 and 501, that these three positions in the receptor binding domain and also the N-terminal domain, which confer on the virus particular resistance to vaccine-induced immunity. And that was really a major problem in management in South Africa. Because if you looked at in vitro neutralization tests using both a pseudovirion mutant assay, which was done in Johannesburg, and a live virus plaque assay, which is done in Durban, we saw that even with the messenger RNA vaccines, there was quite a bit of reduction of neutralization, obviously not nearly as much as with the alpha variant. So there was 6.5-fold, 8.6-fold reduction with the beta variant. And when we came to a vaccine like AstraZeneca, there was up to 86-fold, and in the majority of cases, a complete knockout. There was no, in fact, neutralization from AstraZeneca-induced immunity in terms of the neutralizing antibodies. Again, to emphasize, neutralizing antibodies are not the only correlate of protection. We know that, but it does seem to be an important measure certainly of vaccine efficacy in vitro. And probably one of the main reasons, I think Monica also alluded to it just now, is that the spike protein is not stabilized in the native antigen, and in the messenger RNA vaccines, also in the Johnson & Johnson vaccine, there's a proline which stabilizes the prefusion spike protein, and that way produces a much higher level of antibodies. We see it here, for example, if we compare Pfizer with convalescent serum, human convalescent serum, you see there's significantly higher titers of neutralizing antibodies as compared to post-infection antibodies over here. And when we look at the AstraZeneca, in fact, it is even slightly lower than convalescent plasma samples. So we took the rather painful decision, because we had 1 million doses of Pfizer already in the country in February, and another 500,000 coming later, to in fact suspend the use of AstraZeneca because of the dominance of the beta variant. Fortunately, we were able to substitute, in fact, only there was a 2-day delay, substitute with Johnson & Johnson, and that in fact started the rollout, which is now confined to the 2 vaccines, Pfizer and Johnson & Johnson in South Africa. Then when we come on to the 3rd wave, which now looking to be the most severe wave of all, this is in yellow is the beta variant, which was the dominant variant until about May. And towards the latter part of May, we then started, like what's happening all over the world, being replaced by Delta variant. I'm saying being replaced up to 2 weeks ago, because obviously there's a bit of a 2-week delay in doing the genotyping. Delta was about 75% of all the strands which were genotyped in the country. So that's genotyping. Now, if you look at serological surveys and the problem of immunity. So there have been a number of seroprevalence studies done in South Africa, and I won't go into detail just in terms because of time constraints, but it looks, if you look at the various samples which have been looked at, residual laboratory sera, blood donors nationally, a random sampling in a shopping complex, cross-sectional community, antenatal survey, and you saw right up to 60% of those who were sampled had antibodies, demonstrated by anti-spike ELISA commercial testing, either using the Roche, the Abbott, or the Wantai testing. But on an average, just say about 40 to 50% of individuals have got antibodies. Now, if you do a calculation of herd immunity, I won't go through all of it, but if you take a RT value, effective reproductive number, of 1.97 even, it's actually 1.31 at the start of the epidemics. That was what was calculated in our epidemics. Add another 50% for the variants. 1.97 is quite a hefty reproductive value, we get a required herd immunity of 49%, which is more or less what the seroprevalence studies tell us the population has already got from natural immunity from the previous 2 spikes. And yet we still get this massive third wave, which is now still increasing and is certain to overtake our second wave. So if we look at the first wave, clearly that wave was caused by a population which was totally susceptible. And that was obviously the ancestral strains, the Wuhan strain or the D614G strain. The second wave was driven by the antibody-resistant 351 variant, the beta variant. That was its characteristic. The third wave is now being driven by the highly transmissible 617.2 or the Delta variant. The problem is, we look at our management tools, genomic surveillance, as I said in the title, is one step behind. We'll be able to characterize our genomes once we've got them, once it's established in the epidemic itself. So that's not going to be very useful in terms of being able to kind of forestall, be able to prophesy what kind of pandemic are we going to be getting, because clearly that has significant bearing on management, as we saw with the beta variant and the fact that we were restricted to only 2 vaccines. Serological surveillance, as I mentioned, is also not going to be that tremendously reliable. You know, we're getting 40 to 50% seroprevalence, which really is more or less what we get for herd immunity. So really there need to be the development of newer technologies, either genetic newer technologies, maybe better immunological technologies, to be able to more precisely or more usefully be able to see what kind of pandemics we're going to be in the future. So I'll leave it there. Thank you very much for.
Thank you, Barry, for that summing up your experience, which in South Africa, which indeed is a forerunner. We can see you've given us a view of all the variants up to the third wave that you're at least started, at least from what I can understand, is taking over. Okay, thank you so much for that. I understand that you have to go for your next meeting. Is that right, Barry?
Yes, please excuse me. Unfortunately,
sure,
I will have to run off.
I know that you did tell us that, but we do thank you for giving us your time in the midst of your many other pressing appointments, particularly in view of the pandemic and the waves that are coming, in which you are taking an important role there. Thank you very much, Barry.
Thank you.
And we'll now move on to bye-bye, and all the very best. Stay safe and stay well, and wish everyone well in South Africa.
Thank you for having me.
Remembering that we are all in this together. Oh yes, we always love to have you with us. Thank you. Bye-bye. Now, can I get Professor Mary? I'm going to hand over to you now to take over this the next session or the next part of this very important and interesting program. Over to you, Professor Mary.
Thank you, Dr. Russell. And first and foremost, let me just thank our previous speakers, Dr. Nandita and Dr. Monica, for such a wonderful talk, very lucid and very informative talk, and simplified to the maximum and understandable. So thank you very much. And may I request both of you to please answer the questions in the chat box, because we actually do not have much time. I do need to give time to our other panelists to speak. So if you could answer the questions that are there, and much of it is scientific and less of ethical issues. So you all are the experts, so you should be the best people to answer them. So without wasting much time, I'd like to call Professor Primorac from Croatia. May I also request all our panelists to switch on their cameras so that we don't miss you in case. Professor Primorac? Can you hear us?
Yes.
Dragan, Professor Drag. Can you tell us what is happening in Croatia and the various ethical issues that have been surrounding vaccination program there?
Thank you. I've been on advisory board to Prime Minister for the last 1 year, and indeed, you know, as any other nation, we have ups and downs, particularly with I would say with the response to vaccination. I would say about 6 months ago, we did a few serological studies showing that about 25% of the Croatian population been in contact with the virus. And indeed, you know, since Croatia is having about 4.5 million people, but at the same time, we are facing about 20 million tourists who are coming during the summer in Croatia, we are very much exposed to any new variants. So at this moment, you know, vaccination is organized in every single town in Croatia. It's actually available, even in a few places without any appointment. All existing, I would say, vaccines are available. Right now, the government is motivating people to do as much as possible. And I would say the percentage of adverse reaction, it's more or less similar like in any other country. Right now, we are challenging the beginning of the tourist season. And you know, so many people coming from different parts of the world, and even we are having 4 direct flights from the United States to Croatia. And indeed, you know, it's always big debates among physicians, among all intellectuals, you know, regarding the vaccination and regarding which type of vaccine and what will be happening with the people who already had the COVID like a few months ago. So we are trying to handle that properly. We are trying not to push people with the forces, rather with understandings. Why it's important to do vaccination and why it's important to go step further. And I would say, you know, Croatia is doing quite well as a part of the EU community. And happy to tell you that number of the new cases are not more than about 100 and few per day. There are almost no people on the ventilator or what we said on the intubation or respirator at this moment. And that's what is current situation up to date in Croatia. Okay,
but has Croatia insisted on the vaccine passport?
Yeah, indeed. Every single, you know, EU country, we are having internal, I would say, agreement, basically that every single member of the EU is having the full rights for the passport and travel among the countries. Actually, Croatia entered to the green zone a few days ago. So if you are entering any other country of the EU, basically you don't have to present any documents. A few days ago, I was in Denmark, unfortunately, during the football game when Croatia lost. But that's less important. You know, what is important, basically, when we entered to the Denmark, there was no single question regarding any documents because Croatia is a part of the green zone. So the number of the cases is extremely low. So that's what is a good news. But once again, you know, we have to be very, very careful because we are expecting more than 20 million of the tourists during this summer. And indeed, we don't want to have the big panic in September, like what we have last year.
Okay, but are you accepting all vaccines, or is it only the Pfizer
EU,
and
only EU approved?
Only EU approved. Okay, all right. So then the other countries are not allowed to enter if they don't have the EU approved vaccines.
Or negative PCR test, or the negative antigen test, or approval that the person had a COVID during the last 6 months.
Okay, those certificates are valid for you?
Yes, those are valid, and you have to have them from the valid medical institution.
All right, correct. Okay. Thank you, Professor. I'll come back to you. Professor, Dr. Paul, you can unmute yourself. We've had speakers from Kenya, and how is Kenya doing right now in terms of the COVID pandemic and vaccination program?
Well, thank you very much for the invitation and to the previous speakers for their wonderful presentations. With regards to Kenya right now, we've been slowly sloping down a very chaotic third wave that peaked just around March, about 2 months ago. That's around March, but we never really sloped down to normal levels. So in fact, from what a lot of my colleagues in epidemiology are saying is that actually our third wave will be more of a bi-peaked third wave, because we literally reached a peak just around March and April, but our numbers have slowly gone down, but has not really gone down to the lower levels of the 5% positivity rate that is advocated by the WHO. So we've really stagnated around 10%, and slowly again we are seeing our numbers starting to increase. So far in Kenya, we've had a total of about 180,000 cases since the pandemic began in March of last year. And out of that number, we've had about 3,800 deaths due to COVID-19, and just about 120,000 people have recovered from the disease from that period. Now, with regard to the vaccination scenario in Kenya right now, a lot of our vaccination strategies are being driven through the licensing of the AstraZeneca vaccine, and to be more specific, the Covishield vaccine that we've been receiving through COVAX from the Serum Institute of India. And unfortunately, our program really has never really taken off quite well due to the limited access to vaccine. When we started, we received about 1.02 million doses from the Serum Institute through the COVAX facility. And I think about 2 weeks later, we received a donation from the government of India of about 140,000 additional doses, for which we are quite grateful to the Indian government for that donation. And so that is what was used to give people their first doses. And so our vaccination was structured in 3 stages, whereby stage 1, we had prioritized our healthcare workers, we'd prioritized the security personnel, we'd also prioritized our colleagues, the teachers, and the immigration officials. And then stage 2, which was to start about 3 months later, based on the availability of the vaccine, is when we would get now people above 60 years of age, as well as people who had pre-existing comorbidities. And then the third stage is where we now prioritize our sportsmen and people above 18 years with other comorbidities. Unfortunately, when that strategy was being drawn up, we were in our third wave and we were losing a lot of patients who had pre-existing comorbidities, and especially the elderly, people above 50 years of age. And so because of that, since at the time I was also part of a team that was advising the Kenyan Minister of Health, we took a decision that the people above 60 years of age, since they were in stage 2, we actually pushed them up to stage 1 to really try and mitigate the excessive mortality that we were seeing. And so that has been our vaccination strategy. Right now, we are no longer vaccinating people with the first dose because we literally have no vaccine in the country. Oh. And so the people that are currently being vaccinated are people who are now receiving their second dose of the vaccine. I think 1 week ago, we received a donation from the Danish government, about 780,000 doses of their AstraZeneca vaccine. And that is what we are currently using to catch up people who had received their first dose of the vaccine. But as it stands right now, we are not vaccinating anyone who is coming to receive a first dose of the vaccine.
Yeah, I think that that is the saddest part, because there are countries that have not received vaccination, even the first dose for their citizens. And then you see countries who are totally vaccinated and thinking about the third dose and probably the fourth dose. So this disparity is what is really heartbreaking to see, especially in the low and middle income countries. So I hope that this pandemic will slow down for the health system to recover, and also for the health professionals to recover from the effects of this COVID-19. Thank you, Dr. Paul. I will go to Professor Esper. Professor Esper is from Brazil.
So the current situation here in Brazil is not easy. We are now facing what could be called, and it's just a definition basis, but the third wave of cases that we have since middle May or so, and then we reached a peak by the end of June. Number of cases in Brazil are staggering. We have 18 million cases confirmed, and we deem this to be underrepresentation of the total number of cases. And we unfortunately surpassed 500,000 people who lost their lives to COVID-19. Brazil was the ground for several clinical trials in phase 3, trying to demonstrate whether these vaccines were efficacious. We participated, we ran here the first phase 3 clinical trial for Coronavac from Sinovac that presented their results by the end of the early January. And that led to its emergency use authorization in several countries. We also ran here part of the AstraZeneca phase 3 clinical trial. We also ran here the Pfizer phase 3 clinical trial in some of Brazilian volunteers. And we finally contributed with a significant number of Johnson & Johnson vaccine phase 3 clinical trial. Well, unfortunately, the country lost the opportunity to secure access to most of these vaccines early on, but we were able to pick up. So recently, we've been using all these 4 vaccines in our program for vaccination. So up until today, the number of people who were vaccinated has accounted for about 47.8% of the population who received first dose, and 16.8% of the population received the full vaccination schedule. So this is how we are moving forward. Number of cases are in the past week or so declined. Number of deaths also declined, mostly in the elderly population who were first vaccinated. About 50% of those vaccinated received Coronavac, and about 45% received AstraZeneca, and the remainder 5% the other two. But now we believe that we're going to be able to ramp up vaccination, and that would help us facing the pandemic in the future. The concern that we have at the moment is we don't have the Delta variant detected in the country at significant level. So we still have very few cases in some areas in Midwest Brazil. But our epidemic is largely dominated by P1, or what we call the Gamma variant. So this brings me to the fact that the South African data just recently presented here have shown how the takeover of Delta variant in that country that was facing the Beta variant, and we don't know what's going to happen when there is a clash between the Gamma and the Delta variant here, which is something that leaves us with the question: are we going to face the same problems with Delta as other countries have been seeing? So this is out in the open. We still don't have data, as also presented here, whether the inactivated vaccines can prevent severe cases caused by Delta variant. So these are local questions that we need to address as soon as possible. With that, I'll give back to you, and I'm happy to discuss and answer any further questions.
Yeah, I was just wanting to ask Professor Esper regarding, because now I believe President Bolsonaro is embroiled with AstraZeneca vaccine, and there is a problem with that. So probably you may face a shortage regarding AstraZeneca vaccine.
Well, the AstraZeneca is one of the major vaccines used in the country. We have one institution, we have two manufacturers here that are taking over the local production of two vaccines. So Fiocruz Biomanguinhos is located in Rio, and they are preparing themselves to start producing locally the AstraZeneca vaccine. Now, in Sao Paulo, we have Butantan Institute, who is finishing up the plant to produce the Sinovac vaccine, CoronaVac. There is a third vaccine that's under production here, which is called Butanvac, but basically is the Newcastle adapted virus to express spike protein. This vaccine was created by the colleagues at the Mount Sinai and was adapted to be grown in eggs. So you can use the influenza egg plant to produce vaccines. Brazil, Vietnam, and Thailand are in the efforts to bring this into clinic. So this would help us be independent locally for production. Now, the Brazilian government has been involved in an imbroglio of corruption imbroglio and accusations over importation of other vaccines, not the AstraZeneca vaccine itself. But this is all over the news. It's a political turmoil involving vaccine acquisition that it may impact the vaccination program, but insofar the provision of doses in the next couple months may be able to cover most of the Brazilian population, at least the adult population, to receive the vaccination.
Right. Thank you very much, Professor. Professor Lincoln is here. Professor Lincoln from Professor Lincoln, you're there? Yeah. You can unmute yourself. Dr. Derek, can you help? I've sent you a request, Professor Lincoln. Yeah.
Yes. Are you hearing me?
Yes, we can. Yeah, clear.
Okay. Well, first of all, my compliments to the excellent lecturers, Drs. Mandita, Monica, and Barry. Of course, thank you very much to my great colleague, Professor Esper Calas, who was born in my home state, Minas Gerais. It's very proud for me. As you see, he is a huge expert here, and he shown our landscape, our huge population. We're now fourth in the world in terms of vaccination, but different from Canada, that has the population of the state of São Paulo. We don't achieve until now high percentages. But as Professor Esper said, even with the political turmoil, we are about to guarantee vaccination, at least the first and two shots for most or the target population until September, I hope. It's different in the and luckily different in the other countries of Latin America. I've talked with the colleagues from Central America and Paraguay, and that they have very huge problems there, including confidence of the nature of the vaccine. People are refusing to be vaccinated because they don't believe they are receiving real vaccine. So real problems there. But Chile, Uruguay, and Argentina, Brazil, Colombia, Peru, Mexico are doing well. So at least this one. Okay,
a large part of South America is doing well.
Thank you very much. Thank you very much.
Thank you, Professor Ling. Always lovely to see you here.
Well,
okay, thank you.
Dr. Lincoln is the president of the Confederation of the Latin American and Caribbean Medical Association. So he gives us an overview of that big part of the world. Thank you.
Dr. Monica, just a question. You mentioned about all the vaccines, but you didn't mention about the Sputnik vaccine. Because nobody talks about the Sputnik vaccine. Is there a secrecy, or is it?
No, there is no secrecy. And I actually, if I can just have a second here. Let's see here. They actually, I have a...
Because I'm curious to know whether they're there in the EU passport for vaccination.
So that's what the COVAX program was just recently, the July 1st that they reported on that was saying that all vaccines should be considered equal no matter what. The Sputnik vaccine, I had a slide on that actually. They had a great efficacy data. It is the second most available vaccine or approved vaccine in the world. There's not primary data to support what the statement was, but it was presented, or it was found online. I'm sorry, I can actually share my screen if I can find that slide.
Shall we give you time or come back to you? Is that okay?
Here, I have it right now. I'll just share my screen for a second here. And what you can see here is that this was data that was released just recently, and it was from information of December 5th, 2020 to March 23rd, 2021. They vaccinated 3.8 million Russians with both components of the Sputnik 5. They found that the infection rate starting from day 25 after the first injection was only 0.027% compared to 1.1% for a comparable period. This vaccine's approved in 60 countries, total population of 3 billion people. It ranks second among the vaccines globally in terms of the number of approvals issued by government regulators. So the question that you're asking is, where is this in terms of approval for universal acceptance? I think that because this has been approved in so many countries, and this may be the vaccine that you might be seeing that most people have gotten, that they should not be limited because they received a specific vaccine.
All right, okay. Thank you very much. So marvelous to see everything at your fingertips, Dr. Monica. It's all there.
It's
Lovely.
wonderful.
Yeah. Professor Dragon, just an ethical question. Was there concerns regarding taking the vaccine on religious grounds in Croatia?
Well, I mean, you are having a few issues in the generally speaking in the EU. At the beginning of this year, European Council or Council of Europe issued a resolution that basically nobody can be forced to be vaccinated.
Okay.
And that's something which exists, between people discussing. That's why my strategy is completely different. Nobody should be forced, but everyone should be educated. It's not a matter just that you receive vaccine to protect yourself. You're responsible for your family, for your society, for your country. And that is the strategy actually what we are currently doing. And it makes me very happy to see the outcome is very, very good. And I should probably give you more information back on your question. Up to date in Croatia, about 37% of the population received at least one dose, okay, while about 29% are fully vaccinated. That's the last information we have from this morning.
All right. Okay. Thank you. Thank you very much, Professor. I think we have exceeded our time. We are past 8 here in India, and I'd like to thank all our speakers and panelists. It's been wonderful, a very educative session. And I'd like to use the last words using Dr. Nandita's term, which is ikigai. Yes? Is that right? Yeah, Professor Nandita? So to all our panelists and our speakers, and also to our participants, keep that in mind, exactly what Dr. Nandita said. Do what you love and do what you're good at. And that is where we all can progress globally and as a community. So thank you very much to all our speakers and our panelists and our participants for a wonderful discussion. And Dr. Russell, would you like to say a few words before we close?
Yes, Thank you. I want to thank all the, first, of course, the presenter, Dr. Monica, for your excellent and, of course, making it so simple and having everything at your fingertips. Dr. Nandita, thank you very much for outstanding setting the scene, as it were. And, of course, Barry continued to do his bringing us for the South African version, which I think is a good indicator of what's been happening and how things have been going. I want to thank again Professor Dragan Abramovic, who, of course, I see you as, he is in both sides of the Atlantic. So he has although you spoke to him about Europe and Croatia, he's got a hand also on the other side of where he's
but Dr. Russell, he wears two hats also. He's a politician and a health professional.
Well, now he's only an advisor to the Prime Minister, but some years ago he was a minister. So you have many hats, Professor Dragon. You have many hats, right? So that's why he said you're very
yeah. But it's issue. I was telling the politicians are not happy when I'm telling that I'm using or abusing politics to help the science, because primarily I'm professor of the forensics, genetics, and pediatrics. So it's my pleasure to push the politician to the burden to understand what we need and why we have to change society by the use of science. But you're completely right. I'm living on a monthly basis between United States and Croatia, but recently we opened new medical school in Bavaria. So I'm just kind of moderating all these activities, but became also professor emeritus in India at National Forensic Institute just 3 months ago. So I'll be traveling to India more often than I was expecting.
Very good. Welcome.
Thank you. I have to tell you, I was very impressed with the lectures, very precise, and everything was so clear, because the discussion that I was always trying to underline, it's really the point that was published in Science recently, that, as I am sure that current serological tests for the SARS-CoV-2 antibodies do not reflect the richness and durability of immune memory to SARS-CoV-2. That was the standard, the most important message I would like to deliver from my side. And we are working very, very, very strongly to introduce 2 new tests on the T-cellular immunity. So when I have more data, hopefully in 1 month from now, I'll be more happy to share that with you.
Surely we'll get you back to present here, Professor Dragan.
Thank you.
This will go on, and we are in 43, and I'm sure we'll be continuing with our program. And thank you very much, because I agree this has been good, and we have continued to maintain this, bringing this information, but more importantly, bringing solidarity, as you would see, from Africa, from all the continents that are here. And I representing Australia, Des and myself. So we have virtually all the continents bringing home the fact that we are all in this together, and with solidarity and cooperation is Article 13 of the Universal Declaration on Bioethics and Human Rights. And so we continue to do this, and we continue, and I think we'll use Nandita's Ikigai, isn't it, in what we are doing? Yes. Thank you very much, and thank you, Professor Espa Akala. Very excellent presentation, bringing us up to date with what's happening in another very important and big part of the world. We look at South Africa, India, Brazil, and probably UK, Europe, which has been having all these variants and so forth. So we learned a lot from there. Thank you very much for sharing that your knowledge, including the political turmoil that's which we all live in a world that has of politics and science and all this together. So I think that's a great that we brought all this together. And thank you very much. Thank you, Dr. Paul Younger. Thank you for your bringing us up to date with all of us here up to date with East Africa, Kenya, and of course, ethical issues do come up when you brought so clearly the important factors that you're having with in terms of the not having enough vaccines to continue protecting your population there. And I'm delighted that India has been able to support or contribute in some form to helping your country and your region. Thank you very much for bringing contributing from your part of the world. So we sort of brought everyone here, and then of course we had Lincoln, Dr. Lincoln, give us an overview of Caribbean, Latin American, Caribbean medical, which he presides over, the Confederation. So you'll see all of us together will increase our knowledge. We've brought solidarity. We know what's happening. We have empathy. We have compassion, and we are all in this together. Going to come out, hopefully, not sooner rather than later, in a much better world. So thank you once again, all of you. Thank you, Professor Mary, as you always do. And
Dr. Russell, Deborah had her hand raised.
Oh yeah, I was going
Dr.
to.
Deborah, you have a comment.
I was going to call Deborah, because Deborah is part of our committee, as well as Jasna. Both of them have taken a role in this with yes, Deborah, you have something to say? And
yes,
are you also very proud of Professor Callas?
I just want to congratulate all the finalists here and say that here in Brazil, we are very happy because now we have a Minister of Health that is a doctor, the medicine doctor, and now the thing is getting better. It's okay, Dr. Esper. Now the thing is getting better now because our minister is a medicine doctor. He's my close friend. And I want to invite him another time to talk with us. It will be very good.
So we'll have him.
And we are very, very better than the neighbors countries here. Latin American, it's not very good than we think. Paraguay, as Lincoln said, it's a terrible situation there. So thank you very much to be part of your program. It's an honor for me.
No, thank you.
Have a good week, safe and well.
Thank you all. And we have Professor Dragon, you got another as a doctor, as a minister.
Colleague minister. Yeah. That's good strategy.
So we have not only in Europe, but even in South America, we have. So that's a very good.
If you allowed me, I just would like to say, as somebody who is really living in the two continents, I really would like to thank you and all organizers. It's an incredible meeting, and rarely I see that we share such solidarity between continents. And I completely agree. You have 100% of the support, and I'll do anything from my side to help you in the future. Thank you.
Thank you very much. And that's what we're doing. Right from the time this started, March 2020. So thank you all, and all of you. Stay safe, stay well till we meet again, and we'll be meeting. We usually meet every 2 weeks, and have.